from you. So as I mentioned at the beginning, I'm Dr. Bryan. I'm an associate professor of infectious disease here at WVU in Morgantown. And then I'm also the director of our regional partner site for the Mid-Atlantic AIDS Education Training Center. Sorry, I have a motion sensor light in my office. It always goes off on me. I do have just kind of a few introductory slides that we do as part of our Mid-Atlantic AIDS Education Training Center, or MATEC. We are a co-sponsor for this Project ECHO, along with our CTSI colleagues. And so we are supported by the Department of Health and Human Services and HRSA as part of our grant, with no other additional non-governmental sources. And really our aim is to provide HIV training and technical assistance to the states you can see there in Region 3. All the contents for today's presentation are mine and don't necessarily represent any official views or endorsement from HRSA or other government agencies. And then again, that's our funding grant from HRSA. And again, these are not necessarily official policies from DHHR. You may see some brand or trade names. I think Kaylee used a couple of those. I don't have any disclosures to disclose in that sense. Truly, we end up using them a lot just because it's a lot easier to say, especially for some of these co-formulated medications where going through all the generic names can be a bit of a mouthful. And most people do tend to be a little bit more familiar with brand names from an education perspective. If you're not familiar with AIDS Education Training Center, so it is a nationwide network throughout the country. There are multiple ones. Ours is the Mid-Atlantic, and our headquarters, we're there in the bright red on the right, and the headquarters is based out of Pittsburgh with UPMC. It also includes us, Maryland, Virginia, DC, and Delaware. And there's just another view with that a little bit brighter. Just want to provide everybody with some additional fantastic resources. So there is a National Coordinating Resource Center, which is really a central web-based repository for the AETC program. So there's lots of resources there if you want to learn more. There's also some clinical tools available there as well. Just want to make sure you're aware of the National Clinician Consultation Center that provides free peer-to-peer expert advice for HIV prevention, care, and treatment topics. So if you ever have a patient in front of you and really need some advice, that's a great resource. And then there's also a national HIV curriculum through the University of Washington, which is free. Does also provide CME credits if you want to learn a little bit more about caring for patients with HIV or at risk for HIV. And then again, as I mentioned, we don't have any conflicts of interest, either myself or any of our planners. And then just one final note on our evaluations. So we have updated our evaluation and certificate process if you've attended other MATEC events. So you will receive an email from MATEC with a link to complete and submit your evaluation. And then once that's done, you will get an attendance certificate if you're looking to download that. If you are interested in nursing or other types of CME credit, you can also request a CME certificate by sending it to this email address within 1 month. Okay, and then any other information you'd like about MATEC, there is the website there, which some of you might have registered for today's event through that, or you can call that number. All right. Site assistant content for today. So objectives for today is to really spend some time discussing the clinical rationale and evidence for HIV treatment as prevention as a concept. And then look at how access to HIV care in rural areas, because that's most of our state here in West Virginia is rural, impacts that use of HIV treatment as a prevention strategy. And then talk a little bit about Rapid Start and why we feel like that's really a great opportunity to both benefit our patients who have HIV and also help decrease HIV transmission. So I'm going to spend a little bit of time talking about just a step back globally. This Project ECHO is really focused on HIV prevention and looking at all the different prevention options. So we have, kind of addressing what the risk factors are, whether they're sexual or substance use risk factors or perinatal risk factors. And then at the top there are kind of our pharmaceutical options. So PrEP or pre-exposure prophylaxis, post-exposure prophylaxis, which we'll discuss more in detail at a later session. And then today we're going to focus on that one at that top, which is this concept of treatment as prevention. sometimes also called U equals U. All right, so getting into that. So when we talk about taking care of individuals who are living with HIV, we really have developed this concept of a continuum of care, where we start at the beginning with somebody as soon as they're diagnosed with HIV infection, brand new patient, brand new diagnosis, and that's a big part of it, right? So testing. We spent our last session last month talking about testing and making sure that we're providing frequent testing for those who are at risk, and also universal testing per the current guidelines. So with frequent testing and identifying those individuals who have HIV. So once that person has been diagnosed, really the next step is to do linkage to care to get them in with a provider who's able to provide HIV treatment as soon as possible. And then as Kaylee was describing with her patients, really keeping them engaged or retained in care. And sometimes, that can be a really big challenge. And again, it's usually a lot of psychosocial barriers. Here in West Virginia, we have a lot of transportation issues. And so that's a big barrier for our patients. We don't have like buses or trains that can bring patients from several hours away to get to us. And then getting them actually prescribed antiretroviral therapy. And then ultimately achieving virologic suppression. So our goal is to really kind of shorten the timeline where it takes to really get, somebody as soon as they're diagnosed with HIV to actually get them virologically suppressed. But at any point in time, our patients, we like to keep them over here on this purple side, but at any point in time, due to different things that happen in their lives, they can move in and out along this continuum. So when some of the good evidence for why we feel like treatment can also serve as a key prevention measure. So when we look along that continuum of care, all those different stages, there was a key study out of the MMWR from 2019, where they looked at individuals who had HIV but weren't aware of their status, who had HIV and knew that they had it but weren't engaged in care. Had individuals who are receiving treatment but hadn't actually achieved that virologic suppression, and then individuals who were taking antiretroviral therapy and virologically suppressed. And so the key finding from that study, my box is a little bit of a different spot there, but was that those who were taking ART and virologically suppressed, and here on the bottom one here, which was about half of these people, had were accounted for 0 transmissions. So none of those individuals on treatment who were taking their medication had a known undetectable viral load spread it to anybody else. Most of those cases were actually either from people who didn't know they had HIV or from those who were involved in care. So virologic suppression really does play a key role in preventing forward transmission of HIV. So what's the rationale? Why do we think that is? So HIV transmission risk really does correlate very strongly with the viral load. The major risk factor for HIV transmission is how high that viral load is. And all patients actually have a little, it can vary from patient to patient. Each patient can have sort of their own individual set point. So that sort of depends on, interaction between their immune system and the virus at any given time. So some patients may have in the hundreds of thousands, others might, be in the low 100s. It just really depends. But the higher that plasma viral load is when we draw their blood, the more likely they are to transmit HIV for any given exposure. Antiretroviral therapy, we know, lowers that. And so therefore, whenever they're taking antiretroviral therapy, their viral load comes down and therefore they're less infectious to anybody else. Some of the clinical trial data for this, there is pretty robust clinical trial data, particularly for sexual transmission. So the Partner 1 study was done in 2016, and this was a prospective study across 75 sites in 14 European countries, where they really studied serodiscordant couples. So that's just like the couple that Kaylee described, where one partner was living with HIV and taking antiretroviral therapy, and the other partner was known to be HIV negative. And they reported on their own that they engaged in condomless sex. So this study went from 2010 to 2014 and included both heterosexual couples and MSM couples. And their final results from studying those couples, there was effectively 0 transmissions after an estimated 58,000 individual episodes of condomless sex. And so this is just sort of a summary figure from that study, where again, a pretty broad study that as long as the HIV positive partner was undetectable on their treatment, that they were not transmitting. There was a follow-up study done, partner 2, that where they recruited and followed just same-sex couples and enrolled those serodiscordant couples from the 2010 to 2017 study. And again, where the positive partner had a viral load less than 2,000. And again, they still saw 0 transmissions among 782 couples with an estimated 77,000 individual sexual acts. So again, the conclusion from these 2 studies is that the risk of HIV transmission in couples through condomless sex when the viral load is suppressed is effectively 0. So based on these studies, the CDC has actually endorsed this as a concept. And so this is a statement that they released in 2017, that people who take antiretroviral therapy daily as prescribed and achieve and maintain an undetectable viral load have effectively no risk of sexually transmitting the virus to an HIV negative partner. So there's a lot of caveats in that. So we're going to touch on that a little bit. So the concept of does treatment as prevention mean 0 risk? So I think you can see Kaylee's case really illustrated this very well. So treatment as prevention really requires achieving and maintaining that undetectable viral load. So they really so the antiretroviral therapy and treatment only works when patients are able to take it. If they stop taking their medication, they will experience a viral rebound, and that's going to again increase their risk of transmitting the virus to somebody else. So the success really depends on being able to have programs that are helping individuals remain in care, addressing any barriers they may have to getting their medications, whether that's insurance, whether that's getting to doctor's appointments, whether that's like remembering to take their medication every day, whatever their barriers are, substance use that are and make sure that we're addressing them so that they can be sure to take their medication. The other thing to bear in mind is not all transmission risk factors are equal. We do think, and we do have good evidence that treatment definitely decreases the risk for all other types of transmission, but nothing is quite 0 the way we see with sexual transmission. So this is also from the CDC. So for sexual transmission, whether that's vaginal or anal or oral sex, as I showed you, the partner studies showed no risk of transmission. As opposed, whereas pregnancy, labor, and delivery is estimated to be around 1% or less. And that's also includes post-exposure prophylaxis for the infant. As far as sharing injection drug use equipment like in syringes or other equipment, we don't have a definite number on that, but it's also likely to be much lower. And then breastfeeding does also substantially reduce the risk for HIV transmission, but doesn't quite get it eliminated all the way to 0, the way we see with sexual transmission. So that CDC statement and the concept of U equals U is really something to bear in mind primarily for sexual transmission as the risk factor, but it definitely helps with other types as well. The other thing to be mindful of is not all types of sex are created equal as far as HIV transmission. So probably the highest risk for acquiring HIV would be receptive anal sex, whereas vaginal sex or insertive anal sex are lower likelihood and with no estimated transmission from kissing, touching, or oral sex recommended. So there is differences, and so that's why Kaylee always does a very thorough sexual history with her patients and really spends a good bit of time talking with them, and we try to do that as well to really kind of understand where they're falling at on this risk spectrum. I want to touch a little bit on treatment as prevention and breastfeeding, just because there have been some updated guidance on this in the past couple of years. So we definitely know that there's a risk reduction for women with HIV who want to breast or chest feed. But no studies have really gotten us down to a complete zero risk. So our best estimate came from a 2017 meta-analysis where the reported transmission risk was about 1.1% at age 6 months and about 3% at age 12 months when the infant was breastfeeding from an individual virologically suppressed on ART. By comparison, in the pre-ART era, the transmission risk was about 15% at 6 weeks, not 6 months, and about 32% at 6 months. So about a third, infants had about a third of a risk of acquiring HIV through breastfeeding from an individual who is not on treatment. So definitely a substantial reduction. So what are some reasons for that residual risk? So breast milk actually has a lot of immune cells, up to 1 million immune cells per day and 150 million over that 6-month period. And so we know that the immune cells are the ultimate target for HIV. So because it's so concentrated with those immune cells in the breast milk that the likelihood of the infant acquiring HIV from one of those cells is a little bit higher. Also, breast milk induces immune activation. And HIV replication can also be 10-fold higher in that milk compared to what we see in the serum. There's also the idea of latency. So even for individuals who are on treatment, the HIV, they do still maintain a reservoir of HIV cells with the DNA. And there's latently infected cells that can also be transmitted in breast milk. And then there's also immune vulnerability for the GI tissue. So the GI tract actually has a decent amount of lymphoid tissue in it, which can serve as a site for acquiring HIV infection. So these are some of the reasons that we think we can't quite get that risk down to zero for breastfeeding. But with all that being said, in January 2023, the Health and Human Services HIV clinical practice guidelines actually updated what had previously been our guidance. So in the U.S. And most Western countries, there had been a full stop, not recommended for individuals with HIV to breastfeed, just without question. So in January 2023, they updated them to really kind of move toward evidence-based counseling and shared decision-making. And just really explaining to the patients that the transmission, to the infant would be zero with formula or pasteurized donor milk. But if they did wish to breastfeed, that the risk is probably around 1%, as long as they're taking their medication regularly and they have a sustained undetectable viral load. So that's a little bit on breastfeeding I wanted to share with those updated guidelines. And then I wanted to segue a little bit and talk about, some of the struggles that we have here in rural areas where with HIV access to care. So people with HIV in the U.S. in rural areas like here in West Virginia and other areas are actually less likely to be engaged in care than those who reside in urban areas. So they're more likely to delay HIV care, they're less likely to be retained in care, and they're less likely to be virologically suppressed. So we do have a lot of challenges that we're facing here with our rural patients. And so this is some of the data behind that. So this is a 2019 article where they looked at the geographically accessible distance that patients would have to travel in order to receive HIV care. So here, the darker the red. So this is looking at a 30-minute drive, and this is West Virginia right here. Versus potentially a 60-minute drive. And so a lot of our patients potentially have to do an half hour or more. And if you don't have a car or somebody who can drive you or money for gas or a lot of other issues, it becomes really hard to just get to a provider who can provide treatment. In addition to just reaching the clinic sites, there's actually less HIV workforce capacity in rural areas. So this is kind of looking at the the southeast quadrant of the United States, which is where we see the majority of our new HIV cases nationwide. And so here's West Virginia again. And so this is all HIV clinicians, any HIV provider who's ever prescribing treatment. And so the urban counties are gray, and then those rural counties or the darker gray. And so you can see the rural counties have a lot fewer providers. If you look at HIV experienced clinicians, which this study really only defined as somebody who has at least 10 patients, then it gets a lot more even sparser to have access to care. So it's definitely a big challenge in rural areas. So some strategies that we have to try and use in rural areas to increase access to care. So telehealth has been a really big one. And so doing telephone visits. So in West Virginia, we don't even have the best broadband. So even doing like video visits is a challenge. So telephone visits or telehealth visits. And then also looking at policy efforts to expand the scope of practice for mid-level providers who provide care. And then also providing HIV management and education to our current rural healthcare workforce, through things like Project ECHO and our AETCs to increase, primary care providers' comfort level with at least doing some basic HIV management. And with that, I wanted to spend a little bit of time talking about rapid ART. So more, in the past several years, the movement has really become to starting treatment as soon as possible. So hopefully I've convinced you that that's definitely going to be in the patient's best interest. The sooner they're started on treatment, the more immunologically, so more likely they are to have an intact immune system, and now the less likely they are to transmit. So if possible, we try to do that even in the first clinic visit or even the same day as they actually get the diagnosis. So really getting them started on treatment as soon as possible. Some of the benefits, so again, reduces their time for linkage to care, reduces time to get them virologically suppressed. And so by extension, that is going to decrease their risk of forward transmission. And then also may ultimately also decrease that HIV reservoir for individuals if they're diagnosed in the setting of an acute HIV infection. So who would be a candidate for Rapid Start? So really almost all individuals with a confirmed new diagnosis of HIV should be evaluated and considered for Rapid Start treatment. Those who with a suspected acute HIV diagnosis that even hasn't yet been confirmed, or a chronically infected patient who's returning to care, if you can predict or know what their previous resistance pattern has been, so you could make sure that tailor their therapeutics appropriately. Individuals we probably would not consider it for or would be those with certain untreated opportunistic infections. The main one here truly being one called cryptococcal meningitis is one where we sometimes have a little bit of pause. Individuals who have a positive rapid test, but they have a low pretest probability of infection. So you probably really want to wait on that confirmatory test before starting them on treatment because it might be a false positive. And individuals who themselves don't feel like they're ready to start taking the medication. So in summary, so treatment as prevention is a key component of decreasing HIV transmission and ultimately ending the epidemic. And we do have some disparities in accessing HIV treatment in our rural communities. So we're trying to develop other strategies to fully realize the potential of it as a prevention tool. And then thinking about rapid ART initiation to provide both clinical benefits to people with HIV and decrease transmission to the community. That's all I have. There's our contact information for myself and our regional coordinator, Alyssa Bush. And then the main contact information if you have any follow-up questions for Pittsburgh.
All right, Dr. Bryan, you did have some questions in the
I didn't see any of those. Okay.
Chat box.
I didn't see. All right.
First, you had, how long does it take from initiation of treatment to attain U equals U status?
That's a fantastic question. So right now, our therapeutics are really very potent. Most of our patients are on an agent like Biktarvy, which Kaylee mentioned, that has an integrase inhibitor component to it, and they're actually pretty potent at bringing down the viral load. So it really does depend a little bit on what their starting point is as far as their viral load. So I mentioned everybody does have a slightly different set point. So if they're coming from a really high set point, it might take a little bit longer to get them completely suppressed versus if it's a lower kind of set point to get them down. Most patients, I would say, are probably undetectable within 4 to 6 weeks. We don't have quite as much data in terms of at what point their body fluids, like semen or vaginal fluid, would be undetectable. But we think that most of the time, by the time they reach that undetectable level, they're pretty low risk for sexual transmission. So that's a fantastic question. And I think there might be a question for Kaylee in there. So
what we tend to do is for U equals U is counsel the patient that once their partner's been undetectable for 6 months, then if they wanted to come off of PrEP, then that would be reasonable. But I do have a fair amount of patients that just feel more comfortable from a prevention standpoint on their end that they just want to continue the PrEP too, which I think is certainly fine.
My 4 o'clock.
With that, Kaylee, because from the PrEP patients, from that patient's perspective, you're really relying on the other individual to be taking their medication regularly. So so I think there's a little bit more empowerment if they're taking the PrEP themselves. If they, that they're not always, having to, what if that patient forgets their medications, or what if they have issues getting their prescription filled, if they want to kind of take measures to do their own protection. I think there is a question for you, Kaylee, or I can answer it. If your patient was HIV positive while she was taking Truvada, and there was concern for resistant virus, would she qualify for rapid ART with? Oh, okay. TAF, FTC, darunavir, and Covistas. That's a pretty good question. So we would definitely send a genotype on that patient. And actually, we are going to do a session in a few months. I think Dr. Swari is going to help us out and talk about how we approach patients who acquire HIV while they're taking PrEP. But from a treatment perspective, we would send a genotype. And then, you can, that would be one that you could consider. So a boosted PI would be one that you could consider, particularly if, like Kaylee's patient, we knew her partner was taking an integrase inhibitor and we wondered if there was some resistance. I think that as TAF, FTC, and boosted darunavir would be a decent starting point for that patient to get them started on treatment. But we would still have to send a genotype to see exactly what, if any, mutations she had acquired. That's a great question. Oh, and then somebody also mentioning we have the West Virginia Academic Mentorship Program to train providers. Thank you.
I have a quick question.
Yeah, go ahead.
Yeah. So Kaylee's patients, what if the role was reversed and the female was positive, the male was negative? What would his chance be in getting HIV?
Yeah, so that goes back to kind of the chart I had on that one slide where it's looking at different types of sexual intercourse. So insertive vaginal intercourse is probably is on that kind of lower end of that spectrum.
Okay.
If the female patient was on treatment and virologically suppressed, then the U again within 6 months or so, then the U equals U would still apply in that situation. As far as her treatment, as far as her HIV treatment on pregnancy, so there actually are guidelines as far as what are the recommended antiretroviral therapy regimens during pregnancy. So we actually do have experience with treating women who are living with HIV throughout pregnancy and maintaining that virologic suppression.
So he would be at a lower risk since.
Yes, he would be at a lower risk based on the intercourse type.
Correct. Okay.
Also, if she were undetectable, then that would also be a lower risk.
Okay. Thank you.
Oh, go ahead.
Add anything to add? I was actually asking if you have anything to add, Kaylee.
I was just going to add that, that's also in the context of, are they mutually monogamous? Because remember, a lot of our patients have external partners too. So even with the U equals U campaign, of the patients that were the serodiscordant couples, the patients that did acquire HIV in that study acquired HIV through a third party. So just to consider that too.
Yeah, I think in the partner trials, the few participants who did acquire HIV during that study, they actually were able to attribute to a different. They were actually genetically to look at the virus and determine that it was not the other partner.
Yeah, it was a third party, so it was an additional partner that they had been having, and that's who they acquired it from, not the actual partner that was HIV positive on treatment and undetectable. So, but just something else, because I do have a lot of patients that they have multiple partners. They might have a primary partner, but they also have additional partners. So I would still counsel them the same with PrEP, even if they're at risk with their primary partner who was HIV positive. If the roles had been switched, I would still, counsel them the same way that I would still recommend them be on PrEP.
Okay. Thank you.
And then one question about partners of individuals. Do we receive PrEP or PrEP if their partner is virologically suppressed? So I think you touched on the PrEP part of that, Kaylee. That there can still be a role for PrEP in those patients if they're who are in a relationship with somebody who's on ART and virologically suppressed. As far as post-exposure prophylaxis, we will again have another session focused on that. So I think it's great that you guys are mentioning it. But post-exposure prophylaxis, we really think of that as sort of it's definitely a tool in our prevention handbook, but it's not, it doesn't really take the place of PrEP. So the way we approach post-exposure prophylaxis is for an individual high-risk encounter, so such as like a needle stick injury or a high-risk sexual encounter with somebody who's known to be positive or their HIV status wasn't known, then we would provide post-exposure prophylaxis. That's the medications for that are slightly different. It's actually a fully active HIV regimen. So it's not just Truvada or Descovy, but you would actually do a fully active regimen and add, a third agent in there. There's different ones in the guidelines, raltegravir, there's different ones. But you give them a fully active regimen for a full 28 days. And that really is effective. It was really initially studied in the context of preventing like for needle stick injuries in the setting of healthcare workers, but we find that it applies to other risks as well. And actually one of the indications to start PrEP, maybe Kaylee can touch a little bit more on this, is actually somebody who's who's required post-exposure prophylaxis on several times in the previous 12 months. I think it's 2 or 3 times in the previous 12 months. That's definitely somebody that you would want to do a better job as far as PrEP goes. And that's actually one of the indications in the guidelines. So that's how we approach post-exposure prophylaxis. So that's more of an episodic high-risk single encounter as opposed to kind of ongoing transmission risk is sort of how we characterize those and separate those out.
Yeah, and I agree with that, Dr. Bryan. For this question, if the partner is HIV positive and virally suppressed, I would not feel it's necessary to start the patient on PEP and then transition them to PrEP. You could just start them on PrEP. But my practice is if I do have a patient that's on post-exposure prophylaxis and they come in my clinic, I don't wait for them to have it on, to have 2 occasions where they've gotten PEP. I just go ahead and discuss with them risks. And if they're perceived to be at a higher risk for HIV, I go ahead and just transition them straight to PrEP after their PEP course is completed.
Great. Those are fantastic questions. Thank you guys so much.
You guys are awesome. I love the questions today. They're really good ones. They make me think.